Hi all, good evening. I'm audible.
Yes, sir.
My slides are moving.
Moving, sir.
Yes, sir, moving.
Okay, we'll start the session and we'll go through a quick recap of the last session. Those who are not attended the session. So the main objectives last time what we discussed is about antibiotic, when to start the antibiotic, and we want to decide to start what antibiotic to start, and how to administer and how much dose to administer, and when you want to change the antibiotic, when you want to stop the antibiotic, what is about the stewardship of antibiotic, and the last thing is about the blood cultures. So with this objectives, we started the session the last time, and we finished only almost 1/3 to 1/4 of this one. So we'll try to finish the rest this time, or we'll go slowly so that everyone can understand, and we can prolong it to one more session. So we'll see how much time permits. And these are the various scenarios we discussed last time. So I'm not going to go scenarios. So when you decided to start the antibiotic, so what are the questions you need to ask yourself? So the first question is, what is the organism you are targeting? And the second question is, you need to know what is the site of infection so that you can choose an antibiotic based on the tissue penetrability. And the most important thing is resistance. So how much resistance is there locally already prevalent? And what the drug is, a bactericidal drug or bacteriostatic drug, and whether you have any culture positivity and a successful report with you. And depending on the severity infection, and you decide to choose whether to give IV or oral. So these are the basic questions we need to ask yourself when you decided to start the antibiotic. And these are the spectrums of the different antibiotics. You please go through that later. And what is the difference between bactericidal and bacteriostatic? And majority of the infections can be treated with bacteriostatic drugs. But if you have an inadequate tissue, like a host defenses, like immunodeficient child, or your host defenses are impaired because of the local site infection, like endocarditis and meningitis, you try to give bactericidal drug. And so any sick child in shock, try to give bactericidal drug rather than bacteriostatic drugs. But other scenarios, static is enough. So these are the common examples of bactericidal and bacteriostatic drugs. And another important is hydrophilic and lipophilic. It determines the tissue penetrability. So lipophilic will have high tissue penetrability, and so that's why in cases of like you want to give for pneumonias, try to give more of lipophilic drugs rather than tissue penetrability. And depending on the CNS penetrability, very few drugs has easy penetrability. But many of the drugs what we are using for meningitis can penetrate the CNS when there is inflammation, ongoing inflammation. That's why sometimes we need to give a normal higher doses of the normal antibiotics what will be for meningitis. And regarding piperacillin tazobactam, piperacillin has some good penetration, but tazobactam has poor penetration, so better to avoid it. So what is MIC? Can anyone simplify? Don't read the definition there. Just simplify it and tell me what is MIC. Because you need to understand what is MIC.
Sir, minimum amount of drug that inhibits 50% of the bacteria or infection.
Okay, how clinically you can talk clinically? I don't want the microbiological definition of MIC. So clinically, how to see this? So clinically, when you're talking about MIC, is what is the level of the drug, like your serum concentration, so above which your antibiotic should be there, and which is needed to kill the bacteria, inhibit the bacteria status, inhibit the bacteria. So if any drug concentration below this MIC is not going to be useful for us. So higher the MIC means you need to give very high doses of antibiotics. So that much amount of dosing you cannot give without any side effects. So that's why we'll tell them as resistance. So MIC is just nothing but it's a measure of potency of the antimicrobial drug. If your MIC is so low, that means your antibiotic is very sensitive. If your MIC is so high that your antibiotic is becoming resistant. So you cannot achieve serum concentration of this much high MICs by giving standard doses. So breakpoint is another thing which will tell that so whether your drug is sensitive, intermediate, or resistant based on the breakpoints. These breakpoints I already told, it is not done by our microbial, local microbials, it's international standards. And what our microbial should give is only MIC. So you have to compare the available MIC, what you got for that organism, to the standard MICs, MIC breakpoints, it's called MIC breakpoints given by international societies like CLSI and UCAST. So you need to choose an antibiotic based on therapeutic index. Therapeutic index is nothing but the sensitive breakpoint by MIC. So you can see here that adjacent to the antibiotic column, you have an MIC value. That is what the MIC you got from your microbiologist. So based on the organism isolated. So they do the testing and they got it. And they will compare it with the ranges given by the international standards. It's called interpreted ranges of MIC breakpoints. So S means sensitive, I means intermediate, R is resistance. If your MIC, what you got is less than the S breakpoint, that means the antibiotic is sensitive. And if it is more than the almost in the range of R breakpoint, that becomes resistance. Anything in between S and R is intermediate. So you need to choose an antibiotic based on the therapeutic index, that is nothing but S breakpoint by MIC. Whichever has higher number, that is a more effective antibiotic. So I think up to this we are clear. So we'll move on to the today's session. So most important thing is we will talk about antibiotic resistance. So in antibiotic resistance, we have three types of 3 degrees of resistance. One is multi-drug resistance. In this, the bacteria will be non-susceptible to greater than or equal to one agent in more than or equal to 3 antimicrobial categories. So for example, if you have like penicillin group, aminoglycosides, and quinolones, and even in these 3 groups, if it is resistant to at least one drug, say piperacillin is resistant, amikacin is resistant, and levofloxacin is resistant, that is enough to say it is MDR drug, MDR bug. So next category is XDR. This is extensionally drug resistant. In here, it will be resistant to majority of the antibiotics, but at least it will be sensitive to 2 or less than 2 categories, at least for one agent in that. So if you have 10 to 20 categories in that, 18 categories of resistance and only 2 categories in that also, one agent will be sensitive for XDR bug. In pan drug resistant, whatever antibiotics you know, it will be resistant to the drug, into the bug. So these are 3 spectrums of antibiotic resistance. So MDR, it will be okay. XDR, more severe and worse bug. And PDR, there's no chance. You cannot make the child survive. If you got a PDR drug, a PDR bug, PDR, whether it's any enterobacteria, so you cannot have any antibiotics to make the child get better. So that's the worst spectrum of antibiotic resistance. So slowly from MDR, we are moving towards XDR, and sometimes we are encountering PDR as well. So if you encounter PDR, that means that is the end story of your child. So this is what we are seeing. So in this oval shape, you can see, so majority of the bugs are still sensitive to antibiotics, and like 1/3 is MDR. In that, only like 10% is XDR. In that, 1 to 2% is PDR. So this scenario might change. So it can move on. Your XDR can increase. Your drug resistance can increase. You can become 50% in the future. So all we have to do is we need to maintain the antibiotic stewardship so that we can decrease the chance for new resistance. So next important thing is when you're treating with gram-negative bacteria, the most important thing you need to deal with what type of resistance you encountered, whether it is an ESBL producing organism. ESBL is extended spectrum beta lactamase production, and next thing is CRE is carbapenemase resistance enterobacteriaceae. So these are two spectrum you need to see. So ESBL is the enzymes which will confer resistance to most of the beta lactams, including penicillin, cephalosporins, and azithromycin. But they are susceptible, these bugs are susceptible to carbapenemases. But if you have an bug, the next level bug, so the resistance to carbapenems as well. So we have very less options when you have carbapenem resistance enterobacteriaceae. So carbapenems are nothing but imipenem, monopenem, like meropenem kind of drugs. So when you encounter ESBL producing bacteria, gram-negative bacteria, you have less options like carbapenems. But if you encounter carbapenem resistant bacteria, then you have very, very less options. And these are the very dangerous bugs. So if you don't have proper drug treatment for this kind of bugs, so they can easily collapse and cannot revive them. So coming to gram-positive, the best example is Staph aureus. In that we have 3 spectrums of resistance. So MSS is methicillin sensitive bacteria. So the drug of choice here is chlorhexidine. And MRSA, so here is methicillin resistant. So we need to go up onto vancomycin linezolid. And recently we are encountering VRSA, this is vancomycin resistant Staph aureus. There you have very less options. Linezolid is one of the options. Then you have daptomycin, quinipristin. So different options are now available. But if you encountered VRSA, that means your child will be less responsive to vancomycin, which is the standard used drug for the Staph aureus. So we already dealt with which antibiotic we started. So based on this kind of things, so you have some 7 to 8 questions to ask before you decided which antibiotic we started. So now you decided. So I am going to start as cephalosporins or meropenem, so based on the clinical spectrum. So now the next question comes is how to administer. So how to administer and how much to administer. These are 2 important questions we need to ask. So how to administer means you can frequently some people are telling you need to give vancomycin very slowly and cephalosporin too slowly, but many times we'll give like a bolus injections, which antibiotics to be given as bolus injections, which antibiotics to be given slowly. So how to decide that which antibiotic to be given slowly, which can be given as a bolus? But many outpatient settings, I think they are still giving us a bolus injections only. So what is the physiology behind this? How to administer and how much time to be taken to administer and how much dose to be administered? So we'll discuss. So before going to that things, we need to understand what the pharmacodynamics of antimicrobial agents. So in that, the killing of the antimicrobial agents is 2 types. One is time-dependent killing. In this, the drug will be effective if the time is more to bind the microorganism. Say, like you are going to kill the organism for a prospective antibiotic, which is a time-dependent killing. It need to bind the organism for extensive time. So rather than the concentration, here it needs more time. Your antibiotic should be there in the bloodstream or on the tissue for extended time, so that it can bind the organism, so that it can induce the killing effect. So this is called time-dependent killing. There's a second group of antibiotics called concentration-dependent killing. They should have very high concentrations at the microorganism. They don't need time-dependent killing. If they stay for a very short time also, the concentration is very high, they lose the killing. These are the 2 types of antimicrobial agents available, and that type is combination of both. So they lack in both ways. Time, they need time as well as concentration. It's a 3rd spectrum of antibiotics. So time dependent will work when they have more time to bind the organism. concentration dependent doesn't need time, but they need high concentrations to bind the organism for induced killing. So we'll see the example. So in this graph, you can see here. So the x-axis is the time, and y-axis is the concentration. And you have a dotted line which is called MIC. So any concentration above this MIC will only induce killing. Anything below that will be useless for us. So first group of drug is time dependent. In time dependent, what you need to see is how much time they are above the MIC. How much time? So the concentration is above the MIC. So for that, you need to give the dosing as such that, so they need to have that concentration above the MIC at any given point of time. So the best examples are penicillins. Penicillins need a frequent dosing, like your meropenem. So they need to be given like 8th hourly, 6th hourly piperacillins. So because each time you are making sure that, so your concentration is the concentration, plasma concentration is above the MIC at any given point of the time, so that they can induce the killing. But if you take examples like aminoglycosides, you can do single dose, single time, like daily one body dosing. So there you're going to give a maximum dose to get the concentration which is way above the MIC. You can see the graph here in the left part of the graph, where Cmax is way above the MIC. So that kind of dosing will be needed for concentration dependent antibiotics. So time dependent, you need to give more frequent dosing, and concentration dependent, you need to give as a OD doses, but during that time they will have very high concentration, so that they can induce the killing that point itself, and the bacteria will take a lot of time to recover from that shot. And we have some antibiotics like vancomycin and all, so they will act as both ways. So for them, you need AUC by MI. So it is the area under the curve. It is not like a single point of measurement like x-axis and y-axis. You have to take whole area above the MIC. So to determine the efficacy of the antibiotic and duration and dosing of the antibiotic. I hope I am clear on this. Any doubts here? This is very important. Any doubt? Can I move on?
Yes, sir.
So make it simple. Time dependent antimicrobials, you need to give more time to act. So you need to increase the frequency. Concentration dependent, they don't need to increase frequency. There you need to increase the concentration by giving a loading dose or OD doses. So depending on that, you need to choose the dose and frequency of antibiotics. And in between people like vancomycin and all, they need to have both actions. Like they need to have high concentration and need to have more time. So for them, you need to see area under the curve. Area under the curve will cover the x-axis and y-axis, so it will be useful for them to monitor their effect. So if you go to examples, we'll understood. So for time-dependent killing, mainly beta-lactams and antifungals like fluconazole. So all the beta-lactams are time-dependent killing. And concentration-dependent killing is aminoglycosides and urinolones. Both is your vancomycin, macrolides, tetracyclines, polymyxins, amphotericin B will comes under both time-dependent as well as concentration-dependent killing. So time-dependent killing, penicillins to be all the time they should be above the MIC, above the MIC, so they need frequent dosing. And concentration-dependent like aminoglycosides, like levofloxacin, the others are giving OD doses. Even amikacin, we are going to give OD dose. So they need, but only thing metronidazole, I don't know why exactly they put a concentration dependent killing, but they're giving 8th-hourly dosing. I couldn't able to get the answer for that. If people can search and post in the group if you can. And like vancomycin and linezolid, so you need to have dosing to get the concentration and as well as timing to maintain the above the concentration above the MIC all the time. So they need both a combination of concentration as well as time dependent. So based on this, how to modify these things. So there's important studies, ongoing studies on prolonged infusion versus intermittent bolus of meropenem. There are a lot of studies on this, and this is mainly adult studies. So what they told is, so if you give prolonged infusion of meropenem, your success rate is very high, and the mortality is low. So this is what published in PLOS One. It's a very high impact journal. So it was based on 6 RCTs and 4 observation studies. So the main agenda behind this prolonged infusion concept is meropenem is time-dependent killing. So if you give just a bolus dose and relieve off, the serum concentration will go down very quickly. So again, you have a number extended amount of time where the drug level will be below the MIC, and your bacteria will multiply further. So that's why they came to a concept of prolonged infusions. And prolonged infusion means at least 3 hours. So if you want to give TAD dosing of meropenem, you need to give at least, each infusion should give at least for 3 hours. That is called prolonged infusion, and which was shown high clinical success rate and lower mortality. And even in pediatric studies, so they given this outcome is there's a decreased mortality in critical care patients, and there's no much difference in like non-critical, like in OP-based patients or ward admission patients, where you're giving meropenem for any UTI and simple UTIs and all. But in clinical sick patients, like in ICU admissions, septic shocks, pneumonias, bad pneumonias, they have shown decreased mortality. So even the like recent systematic reviews, what they published in 2021. So what they told is this type of infusions, prolonged infusions, is shown greater effect on mortality and clinical cure among the critically ill patients when compared to less sick patients. So what I can suggest is, if you are giving meropenem in an ICU patient, try to give at least as an infusion, not like a bolus of half an hour to 1 hour. At least minimum of 3 hours. So only problem with this is you need to have syringe pumps. So at least in sick patients, try to give them as infusions, and rest of the patients, that is your choice, whether you want to give very quicker. But definitely, the quicker the duration you give, the less the effect they can have. But because of non-sick children, I think you can have some time so that the effect will be keep on going, and the organism can be under control. So, but for sick children, you don't have time. You cannot get that much time. So you need to act quickly. So there, no go. You need to give as infusion so that you don't take the risk of clinical worsening. And most important thing is the first dose when you're going to start, don't start as infusion of 3 to 4 hours. So the first dose has to go quickly, and simultaneously you can start the like you can give the half the dose quickly, and rest of the hard dose slowly. Then you can combine the next dose a little earlier. So that way you can get the MIC quickly. If you start only as an infusion, you don't achieve the MIC level quickly. So that's why give the half the dose as quicker, like half an hour to 1 hour, and then rest of the dose as prolonged infusion, and add the next to the dose very quickly, and you can bridge that time. So the important point we have to remember when you're giving as a prolonged infusion. So many of you, because I told to give prolonged infusion, many people will start as a prolonged infusion, and if you don't give the initial dose quickly, so child can worsen in a sick state. So that's why any sick child, you have the dose as an bolus like kind of thing, and the rest of the dose slowly, and remaining doses as an infusion. Any doubts here? I think if people got my point, why we are giving prolonged infusions of beta lactams. Even in drug-resistant cases, what the recommendation is extended prolonged infusions. Like you have to give continuous infusion of 24 hours. So that is what they're recommending even for drug-resistant cases. Where in meropenem resistance, you can try continuous infusions, higher doses, so it can get some amount of effect on the bacteria. So next question is how much to administer. See, it depends on severity of infection. site of infection, and underlying renal or hepatic impairment. So based on severity infection, if the child is sick, you need to go for the highest dose. So if you have 20 to 40 mg per kg of meropenem, you cannot start with 20 mg per kg. You need to go for 40 mg per kg. Depending on site of infection, whether the antibiotic can be penetrable, easily penetrable or not penetrable. So depending on that, you need to go up on the doses. If the antibiotic is not penetrable, like if you are treating a meningitis, the penetrability of meropenem is less. So you need to double the dose. From 20, you need to double the dose to 40. If you have renal hepatic impairment, like beta lactams are mainly renal eliminated, so you need to cut down the dose based on your creatinine clearance. And many drugs, some drugs can be hepatic clearance. So in your hepatic failure, so you need to decrease the doses. And one situation I want to highlight here is there is an augmented renal clearance. In early sepsis, where your renal function will be augmented, so you need to step up on the dose of the antibiotic to show that the elimination is matched with the dosing. So when to change, when to decide about escalation of the antibiotic or de-escalation of the antibiotic. So based on your clinical improvement or worsening, antibiotics. So you send the culture and you got an bug, identified the bug, and you got a suspicious report. So based on these two things, so we need to decide on the escalation or de-escalation. So for example, if you're giving an antibiotic, say augmentin for a pneumonia child, so how to decide an escalation or de-escalation? So we'll talk about, because augmentin is a basic drug, so we'll discuss about escalation. So you're giving for an pneumonia child, you have pneumonia child, and you are given start an augmentin. So when you want to escalate this antibiotic,
No clinical improvement.
no clinical improvement means. So if you give an antibiotic, the first dose, the child will get better and go home.
At least 24 to 48 hours.
24 to 48 hours. Okay, so roughly it's roughly about 48 hours. So for antibiotic to act, at least it's going to take time, and show clinical improvement, you need to give at least a minimum of 24 hours and maximum, like say 48 hours. So 24 to 48 hours is a good call. And if the child is rapidly worsening and you don't want to take the risk, then even in less than 24 hours, you can escalate. So that's a different scenario. So that depends on how sick the child is and what underlying situation you are dealing with. So basically, you should at least wait for 24 hours minimum before deciding about escalation of the antibiotic. And you can still wait even for 48 hours if the reason, like the worsening is not that predominant and improvement is also not that much great. You can go 48 hours. If the child is rapidly worsening, no go. You need to decide to escalate. You need to escalate quickly. Otherwise, you got antibiotic report. So many times the antibiotic report, rather than escalating, you need to de-escalate, because nowadays we are aggressive starting antibiotics. So mainly this antibiotic report will tell us that you don't need that higher antibiotic, and you need to go down to a narrow spectrum antibiotic. So when to stop? So it depends on what type of infection you are dealing with and what site of infection you are dealing with. So if it's pneumonia, the minister guidelines will tell 5 to 10 days is enough. And empyema with a complicated pneumonia, you need at least 2 weeks of antibiotics, and depending on the improvement, you need to decide. Sometimes you need to give to 6 to 8 weeks as well. So meningitis, minimum of 14 days. If it's gram negative, minimum of 21 days. Complicated meningitis or any cerebral abscess, at least you give 6 weeks of antibiotics. Any bony or joint infection, you need 6 weeks minimum. And the only thing is for antifungal, it is not depending on your clinical thing. It's depending on the negative culture. So you need to keep repeat the cultures for antifungal. When you isolated a fungus, you need to keep repeating the antibiotics for every 3 to 5 days, depending on the clinical response. And from the last negative culture, you need to give minimum of 14 days. So that is what the guidelines tells about antifungals. So say today you isolated anti-fungus candida, so you started fluconazole, so you need to repeat the culture again after 3 to 4 days, 5 days. And if you got the negative culture at that point, then you have to start counting the 14 days from that point, not from the today. So that is for the minimum duration you need to give for antifungal. So moving to next important thing, antibiotic stewardship. So you need to know what is the pharmacodynamics, like is it time dependent killing or concentration dependent killing. So whether you need to give continuous infusion of beta lactams. So that makes that your killing can happen smoothly. And you need to know what is the organism I want to target, and whether I can have safe options like narrow spectrum antibiotics to cover this organism. So for example, if you want to treat UTI, you know it's a gram-negative bugs, and you have an aminoglycosis which will predominantly act on the gram-negative bugs in narrow spectrum. So you can try that thing. And most importantly, you need to avoid double anaerobic coverage. Many other times I can see you are giving meropenem with metrogyl, piptaz with metrogyl. So it's no point of giving metrogyl when you already have meropenem and piptaz because they have good anaerobic coverage. So this kind of things we can avoid. And as early as possible, we can switch over from IV to oral medications. The child is good enough to take oral medication because depending on the bioavailability, so oral and IV is not going to make any difference if the child is not that sick and able to take oral. And try to give carbapenem sparing antibiotics. And if you have therapeutic drug monitoring for vancomycin and gentamicin, it's better to do that thing and adjust the doses. And most importantly, you need to shorten your duration based on the clinical response and inflammatory markers like procalcitonin has a very good role in deciding on the duration of antibiotics. So these are the common examples of antibiotics with good anaerobic coverage. You can see your amoxiclavinate, meropenem, piperacillin tazobactam has very good anaerobic coverage. So definitely you can avoid metrogyl when you're already on this kind of drugs. So the next thing is the 5 Ds of antimicrobial stewardship. The first thing is you need to make the right diagnosis, whether it is the viral or bacterial infection, whether to give antibiotic or not. That's what very important thing. And if you start to decide antibiotic, you need to decide what is the empiric antibiotic I want to choose based on your local and international guidelines. And main thing I suggest local epidemiology is the best thing we can follow to decide on the antibiotic. So you can choose what are the commonest bugs on the international guidelines, but susceptibility pattern of the bugs will be determined from local epidemiology. And next thing is dosing. So you need to view appropriate dose in appropriate setting. So in a clinically sick child and severe infections like meningitis, so you cannot view underdosing. So there you need to adjust the doses, and is when you have to adjust dose based on hepatic and renal impairment. And duration, you need to choose the right duration of antibiotic treatment based on the underlying what infection you are. So you need to avoid the longer the better mentality. So it's never longer the better mentality will work. So they can get resistance to the other antibiotic, and you need to move on to the next antibiotic. And whenever you have antimicrobial susceptible reports, so our clinically child is very much improved dramatically. So try to de-escalate. And you prefer monotherapy whenever it's possible. So these are the 5 Ds you need to keep when you're dealing with antimicrobial stewardship. So right diagnosis, right drug based on your international guidelines and local epidemiology, correct dose based on your severity of the illness and underlying renal hepatic impairment, right duration, majority should be shorter duration. Don't over treat, over prolong the duration. And based on the reports and your clinical response, try to de-escalate. So next most important thing, how to obtain blood cultures. It's a very important thing. I think majority of us will be still doing many wrong things, including me till last 1 to 2 years. So how to get the blood cultures. So there are recently, this is the latest evidence from BMJ in 2021, what they published. So what they are telling is, if you're able to get blood volume, larger the blood volume, for culture, it will be very beneficial to identify the pathogen. So what they are telling is, so more the blood volume, the high likely the detecting the pathogen. So you need to get maximum amount of blood. So don't limit yourself to 1 ml or 2 ml. If you are able to get 10 ml, I suggest to go for 10. If you're able to, your culture bottles can accommodate 50 to 20 ml, go for it. So don't hesitate to draw the blood for blood cultures. So more the volume, high likely the positivity of your blood culture. So what they're telling is maximum is 4% of the total blood volume. See, 4% is quite high for any HIV. So you compare how much amount of blood you are drawing and what is the maximum recommended thing for that. So the minimum recommended thing what they given is for less than 1 kg minimum of 0.5 ml. So less than 5 kg at least 1 ml. So depending on this, so if you have children above 5 to 10 years, so at least you need to take at least 10 ml. Even the same thing was given in other IDSA guidelines as well. These are the 2 standard guidelines. So where they prescribe the amount of blood to be drawn. So what I suggest is, if you're able to take extra 1 ml, please take it. It's not going to cause the harm for the child. So, but it can yield the bacteria, and you can decide on the antibiotics. So this is a recent study which concluded that if you take more the volume, like from 20 to 40, 60 ml, so the sensitivities are very high with 60 ml blood sampling. So please take the highest amount of blood what you can obtain from the child. And what the recommendation is, 2 sets of blood culture. 1 set means aerobic bottle, anaerobic bottle. Like that, you need to get 2 sets. So if you're strongly suspecting sepsis, at least send 2 blood culture bottles at the same time. Like when you are doing for endocarditis, infective endocarditis, you're going to send 3 cultures. Why? Because the more the number of culture sets you're going to send, you'll get more the yield. So that is what the recommendation. If you strongly suspect sepsis, at least try to send minimum of 2 sets. 1 set includes aerobic and anaerobic. If you not suspecting anaerobic organism, you can avoid anaerobic bottle, but aerobic bottle, minimum of 2 bottles in strong suspicion of sepsis. If you want to send 3 bottles, fine, good enough. The yield will be very high. And so what we propose to our things like pediatric bottle is yellow bottle for bacterial system is 3 ml and adult bottle is 10 ml. So what I given is infants less than 1 year, at least minimum of 3 to 4 ml into the pediatric bottle, and anything above 1 year you can get 10 ml and put it in the adult bottle. That is what our unit follows. In units, depending on the prematurity, if you have like a 600 700 gram child, 0.5 to 1 ml is enough. But at least take 1 ml. That's what I can suggest. And in term child, 3 to 4 ml, you can put it in the pediatric bottle. And several studies have shown that your antibiotic, if you give an antibiotic prior to the blood culture sampling, it will affect the culture positivity rate by 50%. So if you are strongly suspecting sepsis, try to get the blood culture before starting but don't delay. If you're not able to get the blood culture bottle in the night, don't delay the antibiotic for sake of getting the blood culture. And one more thing is a fever. So don't take time and wait for the fever to occur so that get the culture during the fever. So even in endocarditis, they taken off that recommendation of getting cultures during the time of fever. So it's not that much correlating research wise. So next most important questions when we'll encounter a persistent positive blood culture. So you are giving antibiotics, you are giving sensitive antibiotics, but again the cultures are getting positive. Like we have last time 3 blood cultures positive for fungus. So the same antibiotic we given sensitive antibiotic, but still not responding. So then we need to think about you need to review your antibiotic treatment so based on whether I am giving adequate dose whether I'm able to achieve adequate serum concentration. So whether I need to optimize the drug dosing, whether drug monitoring is needed, whether my child is not able to get adequate dosing, adequate therapeutic concentration. That's what you need to think. And whether I need to change this antibiotic, whether maybe in vitro it is working, but in vivo may not be. So I need to optimize that appropriate regimen and appropriate dosing. So if you still they are not able to get, you can address therapeutic drug monitoring. And second important, source reduction. So if you have a pneumonia child with empyema, how many days of antibiotics you're going to give, how much antibiotics you're going to give, unless you remove the pus, you cannot get the pulse rate down or fevers down. So that's very important to look for the primary source of infection. So you need to, if like a bone is already osteomyelitic and there's a lot of pus in the bone, so you need to drain it. So simply remember, if there's any pus anywhere, you need to drain it. You cannot just give antibiotics and make them improve. And third thing is source control. So like sometimes the central lines will be colonized. So every time if you give some injections from the colonized central lines, it can release in the bloodstream and it can cause the again a second infection. So that is what you need to look for, any thrombus, so septic thrombi. So these are the things you need to look for, and you have to control the source. So when you have persistently positive cultures and clinically not respond. So last topic we want to move is options for resistant gram-negative bacteria. This is the what commonest scenario we'll encounter frequently. So resistant gram-negative bacteria. So already we know what is the ESBL, extended spectrum beta lactamases, antibacterials group, enterobacterials. So this is a simple slide what I prepared from the guidelines. So if you have like simple UTI, then you can try oral antibiotics. And you know, if you have extended spectrum beta lactamases, it will be resistant to majority of the penicillin group of drugs. Very few drugs will be susceptible. Like if you add penicillin inhibitors like clavulanate, sulbactam, then it can make susceptible the penicillin group of drugs. Like amoxiclavulanate, you can try. And the best thing is you need to go for nitrofurantoin and Cepron. So these are the two oral drugs of choice for simple UTI. And you need to avoid these two when you're dealing with complicated UTI. But Cepron you can try in complicated, because the only problem with Cepron is they are bacteriostatic. So we need to think whether initially you need to start bactericidal, and later on you can switch over to oral Cepron, Cepron based on clinical improvement. So any sick child, avoid bacteriostatic drugs, try to go for bactericidal drugs if you have an option. So simple UTI, start with the oral choices, nitrofurantoin and Cepron. Even amoxiclavulanate you can try, but you want to go for IV, you can use single dose of aminoglycoside. Another option is oral fosfomycin, but fosfomycin is only for E. coli. It's only for cystitis. Your nitrofurantoin and fosfomycin will not work for pyelonephritis or complicated UTI. Please remember. So even if your sensitivity pattern is susceptible, nitrofurantoin is susceptible, please avoid them for complicated UTIs. So there you need to choose bactericidal drugs and other drugs rather than nitrofurantoin and fosfomycin. And if you're giving fosfomycin, it is only for E. coli. It will not going to work for any other drug, any other bug. And the last resort we have is fluoroquinolones and carbapenems. You need to try to preserve them for simple UTIs. And in complicated UTIs, you can put fluoroquinolones in the first choice along with Cepron. And if a child is very sick, you need to give carbapenems, and you can always try aminoglycosis. So for bloodstream infections, so the first choice what they prescribed is carbapenems. And you have piptas, one option here. The problem here is a lot of studies which was done in adults, they shown the comparison of piptas with carbapenems in ESBL produced bacteria. The mortality rate was slightly higher with piptas. So that's why what they are telling is if a bloodstream infection with ESBL Enterobacteriaceae, So go for straight away carbapenems rather than starting on piptas. And other options you have is fluoroquinolones and ceftriaxone. So this is for ESBL. So now you have carbapenem resistant enterobacteriaceae. So because of the extended spectrum beta lactamases, so they susceptible to carbapenems, you're not going to start straight away carbapenems for simple UTIs and the complicated UTIs. Only for bloodstream infections, you're going to start for carbapenems. And you try to preserve carbapenems and the last resort for simple UTI. So now we have option for CRE. So complicated, carbapenem resistant enterobacteriaceae. Again, for simple UTIs, you can have nitrofurantoin and ceftriaxone. But the problem with this thing is, once you are getting CRE bug means, they will intrinsically be resistant to other drugs as well. That's the main problem. So it is not only for carbapenems. If they are able to develop resistance to carbapenem means they're already getting resistance to other drugs as well. So the mechanisms are different, but the problem is you have very less options once you got resistance to carbapenems. So you can try the same thing, and last resort for simple UTI, you can give colistin. So colistin monotherapy is advisable as a last resort for simple UTI. And for complicated UTIs, you need to give fluoroquinolones and high dose meropenem infusion is what I'm telling. So if you have a complicated UTI, even though it is a resistance to meropenem, you can give a high dose. Like previously you're going to start 20 mg per kg, you can start with 40 mg per meningitic dose, and you can use extended infusion, like continuous infusion, you can try. They are showing clinically that if you do higher doses, it can help, it can improve the child. So under practicals, we have seen this improvement. I mean, we started on meropenem, so fevers got reduced, and before getting susceptibility report, we have started on meropenem and we got the response. So you can try, if you don't have any other option, you can try high dose meropenem, not a normal dose of meropenem, but you need to give as an infusion. And what other options you have in complicated UTI if you are resistant to fluoroquinolones and meropenem? So the first line, second line drugs, what you have is ceftazidime avibactam, which is the newer antibacterials, and meropenem and vaborbactam, and imipenem, silacin, these are the main combinations of penicillinase and penicillinase inhibitors. So these are the drugs which can inhibit the penicillinase production, so that they can your antibiotics can act on the bacteria. So next options are polymyxin B and aminoglycosides if they are sensitive to that. The last and final resort what we have is cefiderocol, and the availability in India is very less. You need to import this drug. I think in future, I think it will be available for you. But if you have a bloodstream infection, you cannot take the risk of giving fluoroquinolones and high dose meropenem here. So there the first choice is you need to go for newer antibacterials like ceftazidime avibactam, meropenem, vaborbactam, and you can add azithromycin to that. So next choice we have is polymyxin B, tigecycline, aminoglycosides, and they are the second line. You cannot use them as first line. So CRE, you have very less options, and basically the drugs which is available in CRE is ceftazidime avibactam, meropenem, vaborbactam, and imipenem combination of avibactam. And if they are not working, they are become resistant, then you have very less options with polymyxin B in combination with tigecycline, and the last resort is cefiderocol. So these are the three groups of carbapenemases. One is amylase, BD, and there's a certain groups of enzymes in this. A contains the most common thing is KPC. Just remember that word. And in B is Vim and NDM. Remember that NDM, which is the commonest in our areas. So we are encountering more of NDM and less of KPC. And D is OXA48. Why we need to look after this? If you have NDM carbapenem resistant enterobacteriaceae, then your drugs is not going to work. Your vaborbactam, relibactam, avibactam is not going to inhibit NDM. So they can inhibit KPC and OXA48, but they are not going to inhibit Vim and NDM. So we need to combine ceftazidime avibactam with aztreonam to conquer this NDM group of enzyme producing bugs. So the mainly why we are adding aztreonam, because aztreonam will have action on NDM directly. So it's not going to inhibit the NDM, but it's going to penetrate the cell wall and it can cause a damage. But the problem with aztreonam is the same bacteria can produce ESBL. It's not only going to produce carbapenem, it's going to produce ESBL. So aztreonam alone cannot going to work. But if you combine ceftazidime avibactam with aztreonam, this avibactam is going to inhibit the ESBL. So it will not break down the aztreonam. So aztreonam can act. And the mainly avibactam role there is not to act like ceftazidime is going to act on the thing. It's the main action is it inhibits the ESBL and carbapenemases. So your aztreonam can act freely on the bug. So that's why the recommendation for latest recommendation is combine ceftazidime avibactam with aztreonam. That is the last resort apart from cefiderocol. Cefiderocol is not that freely available in India. So till now, what we have option is ceftazidime avibactam aztreonam for this carbapenem resistant bugs, which is NDM producing. So some bacteria are intrinsically resistant to some antibiotics. So based on that, you need to avoid that antibiotics for them when you. So for Burkholderia, they are resistant to polymyxin B and colistin. So you cannot use the polymyxins against them. And for Pseudomonas, you are resistant to tetracycline. So you cannot act tetracycline for Pseudomonas. So this is the things you need to keep in your mind when you are dealing with bugs. And this is a simple summary of the options we have for multi-drug resistance Enterobacteriaceae groups. So if you have Pseudomonas aeruginosa, which is resistant to majority of the antibiotics, the options we have is very less. So you have ceftazidime avibactam and cefiderocol, and you can try polymyxin B for any resistant bug. But the problem is polymyxin B should not give only as a monotherapy. You need to combine them with some other antibiotic. You cannot give polymyxin B as a monotherapy, and they'll be less likely effective for pneumonia. So you need to combine them with other susceptible antibiotics. And if you don't have any susceptible antibiotic, you need to choose an antibiotic which is resistance is almost equal to the MIC. So the MIC is almost equal to the sensitive breakpoint. Say like you have two drugs, aminoglycoside and meropenem. So meropenem sensitive breakpoint is 4 and amikacin sensitive breakpoint is 16. And your MIC for meropenem is 60. And MIC for the amikacin is 32. So for meropenem, it is 4 times the higher the MIC. And for amikacin is 2 times the MIC, sensitive breakpoint. So you can choose polymyxin in combination with amikacin rather than meropenem in this example. So the nearest to the sensitive breakpoint, choose the drug in combination with polymyxin when you don't have option of ceftazidime avibactam and azithromycin. So and recently minocycline, tetracycline are the 2 other group of drugs which is working for the HDR and MDR bugs. And the final thing is the combination and sensitive pattern. So mainly for gram-negative bacteria like Klebsiella and E. coli, it is the depending on the that carbapenem, which is the producing KPCR, NDM or OXA48. So you can try ceftazidime avibactam in combination without combination with aztreonam. And for Acinetobacter, we have less chances. You need to have polymyxin, and because Acinetobacter is intrinsically resistant to aztreonam, so you cannot use aztreonam based preparations for Acinetobacter. So you have narrowed the options to very little now. So you can have combination of polymyxin B with tetracycline. That is the only 2 drugs we can try for Acinetobacter, which is extensive drug resistant. And for Pseudomonas, you can still have an option of ceftazidime avibactam and aztreonam. So there's the main difference when you are treating with carbapenem and Enterobacteriaceae. So last few slides, we'll finish up the session today. So I already discussed it, why you are combining aztreonam with ceftazidime avibactam. So basically, aztreonam is active against NDMs, but it can be handled by ESBLs. So that's why you need to give avibactam to inhibit ESBL, so aztreonam can act. Tetracycline, you cannot give as monotherapy. You should avoid tetracycline monotherapy for any bugs, any site of infection. And the commonest sites you are going to prescribe tetracycline is for intra-abdominal infections, skin and soft tissue infections, bone infections, respiratory infections. They cannot be advisable for bloodstream infections and sick child because it is a bactericidal drug, bacteriostatic drug, and the penetrability is very high, so it will not stay much in the bloodstream. And if you are encounter resistance bugs, you need to do the double the dose. You cannot do the standard dose. So always remember, you need to go for higher doses of the antibiotics when you encounter resistance bacteria. And what are the recommendations on polymyxins? The guidelines tell that you should avoid polymyxins in any of the infections. If you have other options like ceftazidime, avibactam, aztreonam, you need to go for them rather than treating with polymyxins. But if you decided to start polymyxins, you need to have certain guidelines on how to use them. We'll just go through it. So by the newest your antibacterial susceptibility reports, they've taken off S column for them. They removed S column. Even if the MIC is less than 0.5 for colistin, till they'll give us intermediate only. They cannot give us sensitive. Why they given that is, the people should not mislead and give only colistin and polymyxin for the treatment. So always polymyxin B and colistin should be combined with other drug. You cannot give monotherapy of polymyxin B or colistin. Colistin you cannot be given monotherapy. That's why they removed the sensitive breakpoint for the colistin. Even if it's less than 0.5, very less 0.25, they give it as intermediate only because you should not give it as monotherapy. Only for UTI, uncomplicated UTI, you can give colistin. And among polymyxin B and colistin, what is the drug to be given? Polymyxin B given for the invasive infections. You cannot give colistin for the invasive because the problem with the colistin is it has variable pharmacokinetics. Even with the dosing, the drug concentration, the serum will change dramatically. If you change 10 mg per kg, it's going to change a lot of difference. You can get underdosing, you can get overdosing. So that's why they prefer polymyxin B because it has very little bit standard drug concentrations in the pharmacokinetics based on your drug levels in the serum. But colistin has erratic pharmacokinetics and the drug levels will be very variable. So you don't know whether you are getting the concentration at the toxic range or at the underdosing range. That's the recommendations clearly tell that based on the superior pharmacokinetic profile of polymyxin B, you need to give polymyxin B over colistin, and you need to choose colistin over uncomplicated UTI because colistin will be excreted through renal, so it can act at the urinary tract. So for UTI, it is colistin. That to uncomplicated UTI. If you have pyelonephritis, it's again polymyxin B only. Say it's cystitis, go for colistin. Pyelonephritis and bloodstream infection, go for polymyxin B instead of colistin. That is what the recommendations from the latest guidelines. This was the guidelines proposed in 2019. International guidelines for polymyxin use. The different bodies come together and given these guidelines. And colistin dosing also, I think many of them will be underdosing the colistin. So you need to give loading dose. All polymyxins need loading dose. You cannot straight away start the regular maintenance doses. And the recommendation is 0.2 lakhs units per kg. It's a little bit higher dose than standard dosing. And you need to start the maintenance dose after 12 hours. And the maintenance dose is 1.5 lakhs per kg per day, 2 divided doses. Not like 3 divided doses, one recommendation tells 3 divided doses, but it is 2 divided doses, which was given by recent recommendations, guidelines from the multiple societies. So you need to give loading and need to give high maintenance and need the BD dosing. And polymyxin B, it is like 20 to 5 to 1000 units per kg loading dose, followed by 30,000 units per kg, 2 divided doses per day. And the most important advantage of polymyxin B is there is no need for renal adjustment. So that is the main important advantage of policy over colistin. Colistin needs renal adjustment, but polymyxin B doesn't need renal adjustment. So polymyxin should be given combination therapy. You cannot use monotherapy. So you need to choose the other antibiotic based on susceptible pattern. If you have another susceptible antibiotic, you combine with it. But if there is no susceptible antibiotic, so if you have an Klebsiella which is resistant to all the drugs except for intermediate to polymyxin B, you can use polymyxin B, but you need to add a second agent which has MIC almost or near to equal to your susceptibility breakpoint. So choose the drug. So only for Acetobacter, if you can give monotherapy of polymyxin B, if you don't have any other available susceptible antibiotic. So coming to Pseudomonas, so probably Pseudomonas is, even though they are initially sensitive, 3 to 4 days of duration of antibiotic therapy, they can become resistant. So that's why if your child is not responding after that, you need to repeat the antibiotic testing again. So don't stick on that this drug is sensitive to the Pseudomonas, so I'm going to continue for next 14 days. So please try to repeat the culture and see the child is worsening any point of it. Definitely try to repeat the culture. And if the clinical scenario is not that much promising, try to repeat it early 3 to 4 days. You need to repeat the cultures. So the last slide, coming to conclusions. So whenever you're choosing an antibiotic, you need to select the antibiotic based on breakpoint by MIC, which is greater. That's more efficacious. And if you are dealing with sickest children, you need to give the highest dose which is possible. And for sick patients, give meropenem, piptaz, and ceftazine, which are beta-lactamams, as an infusion, not as a bolus dose. You have to give it over 3 hours. And for CRE infections, we have very limited options available. Like example, ceftazine, avibactam, mustard is the only options we have. And if MIC of meropenem is less than 8, you can try high dose asbestos infusion. And you need to use polymyxin B instead of colistin. I think many units are using colistin for bloodstream infections, but try to switch over from colistin to polymyxin B because the favorable pharmacokinetics and no need to adjust for the renal dose. So you need to give loading doses for all polymyxins. Don't straight away start the maintenance. You need to give the loading doses. And polymyxin you cannot give as a monotherapy. You need to use as a combination. This is the first point I need to stress again and again. So polymyxins don't give us a monotherapy. And some bugs which are very much known for drug resistance and kind of thing. So you need to give them dual therapy when sick patients. You cannot give monotherapy. So I like Pseudomonas, Burkholderia, and Stenotrophomonas. So dual therapy is suggestible in a sick patient. And the last important point is try to take maximum amount of blood possible for blood cultures. Don't restrict yourself to the lowest amount. So at least 1 to 3 ml for neonates, 5 to 10 ml for children. Always follow 5 days of antibiotic stewardship. Thank you. That ends the session. Any doubts we'll take. I know it's too much theoretical, but the problem here is you need to know about the knowledge about what are the different pharmacokinetics and pharmacodynamics of antibiotics and what is antibiotic stewardship. So I made it more informative so that we can do in a session if it's feasible on different scenarios with the clinical examples and what is the antibiotic of initial empirical treatment and based on the reports how to change the antibiotics and how to escalate, de-escalate. So that kind of case scenarios we can do in the next session. I cannot promise the next Thursday, but in the future, I think I can promise one session on the case, daily have case scenarios for antibiotics. For that, I think people will be thorough with these 2 sessions. what exactly antibiotics are, how to prescribe antibiotics. And if you don't know theoretical knowledge, you cannot go and do the clinical case scenarios. Yeah, anyone want to ask the question?
Sir, my one question is that is any
Yeah.
benefit of starting like bloodstream infections, second line and third line combinedly, or we should wait for the second line to not responding, then you should think about the third line, or you can add say if the clinically deteriorating, same time second line and third line. Any benefit, any recommendation?
The problem is the combination of antibiotics to be chosen that is based on your underlying child scenario. If your underlying child is very sick, you are not going to give first line like that thing, nitrofurantoin and Ceptra. So there already you are giving the bactericidal drug and like ceftazidime avibactam or meropenem if it's a ESBL producing bug. If you are giving meropenem, there's no point of combining it with polymyxin.
Okay.
Because if the bug is sensitive to meropenem, there's the best antibiotic the bug can get.
Okay.
It's a bactericidal drug and it's going to kill it definitely. The main problem with the combination comes when you are giving like less potent antibiotics. You no need to combine less potent antibiotic with the most potent antibiotic. You got my point. If you have a most potent antibiotic which is susceptible, there's no point of combining less potent with the most potent. The problem arises, the combination occurs when you have a less potent antibiotic. So you need to combine 2 to 3 less potent antibiotics for that bug so that you can get the therapeutic efficacy. But if you have a meropenem which is sensitive, there's no point of combining any drug with meropenem. The only problem here is if you are resistant to meropenem, then you can add polymyxin B with meropenem, high dose meropenem, so that you can some amount of meropenem can act and some amount of polymyxin can act together, so it can inhibit the bacteria.
Okay, sir, thank you.
I think you got my point. So if your
Yes, sir.
UTI drug is bug is sensitive to levofloxacin, which is a bactericidal, there is no point of combining it with the polymyxin or cholesterol.
Yes, sir.
That's all. So if your bug is sensitive to, if you have cystitis and the bug is sensitive to Ceptran, there's no point of combining any other thing. You straight away go for Ceptran, it'll definitely work. But if the child is sick, you're not going to give Ceptran, you're going to give the next biotic, that is bactericidal drug, that is levofloxacin. So there is no need to combine. But the bug is resistant to all these drugs, then you dilemma, you need to combine the antibiotics.
Okay, sir. And my second question is, should you think fever as a clinical deterioration for the resistant, like in enteric fever there is fever, even though
that's what I'm telling. The second point I discussed when during discussion about persistent culture positive thing. If you have fever, you need to think of whether I'm dealing with the same bug or the child got the new bug.
Okay.
Or the fever is because of the infection or fever is because of inflammation. Like your thrombophlebitis can cause inflammation. And you are sure that it is because of the same infection, there's no new infection. And it is not because of thrombophlebitis, it is because of the primary infection itself. Then you need to look for complications. If you are dealing with pneumonia, you need to rule out empyema. If you are dealing with meningitis, you need to rule out cerebral abscess or subdural empyema. You are dealing with any skin infection, you need to rule out underlying bone infection. If you rule out all these things, then you need to think of drug resistance. Then you need to change the antibiotic.
Thank you, sir.
Sir, if we have a sick child who is on multiple antibiotics, but still the cultures are sterile, so how do we go on about increasing, escalating or de-escalating antibiotics?
That Priya, you can better answer that question. That is the most difficult question, and that depends on our clinical experience. So, per se, if you ask my personal opinion, I can tell you, but general guideline, there's no clear-cut guidelines. So if you want guidelines, I cannot give a clear-cut answer for you. If you ask my personal opinion, so first of all, why you want to give multiple antibiotics? That's what the first question arises there. And the second question is, what is the organism you're targeting? If I am damn sure that my hospital will have only 3 bugs, and I am already covering the 3 bugs with a good, like a best antibiotic, and still the child is not improving, means I'm going to suspect whether it's because of the infection or any other process like inflammation, something else. And if I able to rule out all other things, and if I am dealing, I'm damn sure that I'm dealing with only with infection, not with any other inflammation or other kind of things, then definitely whether I'm dealing with the same bug or there any addition of new bug, the most promising way to deal this kind of situation is keep repeating the daily or alternate blood cultures, and even the blood cultures not single bottle. So you need to repeat 2 to 3 sets. The more amount of blood and more amount of cultures you send, definitely you get one yield any point of time. And still all the cultures, like they say 1 bottle 67%, 2 bottles 85%, 3 bottles 95%. So you need to choose. So whether you want to take risk of sending only 1 bottle and getting 67% chance, can miss 35% chance of not detecting the bacteria, or if you like dilemma, first time I send 1 bottle, I'm not able to get the yield. So second time I get 3 bottles with the 10, 15 ml in each bottle. So the yield will definitely increase. And even after that, you are not able to identify the bacteria, then very less likely that kind of situation will be the infectious. And that tells that whatever bug is there, it is susceptible to antibacterials. So try to continue the same antibacterials and give some time for child to improve. That's all. So depending on the clinical improvement, and you can decide which antibiotic you can downgrade, like bactericidal or bacteriostatic. You want to get down first bacteriostatic first and continue bactericidal. And depending on the local spectrum of antibacterial susceptibility, and which is the most important antibiotic for that bug, particular bug which you are in the thought process, even though you not identified that bug. So that you can continue. So simply send multiple cultures and get the bug. Even after multiple cultures, you're not able to get the bug, means that bug what you are dealing is already getting susceptible to antibiotics you're giving. And when your clinical scenario is not very worsening and child is like status quo maintenance, then you need to look for other causes of things where, like we told, any local site of infection, septic thrombus in the because major sick children will have central lines. The commonest site is septic thromboembolism, which can lodge in the lungs and other deep vessels where you cannot able to detect them, but they keep releasing the bacteria, and it can keep prolonging the course of the illness. So this kind of mechanical things we need to think when your cultures are negative and still susceptible infection. And best thing is to send the multiple cultures and look for all the focus of infection. So that is what I can suggest. And de-escalation is depending on the clinical scenario. If child improved without cultural positivity, definitely I try to de-escalate the antibiotics. No go. So even they responded to the last antibiotic, I don't know whether it's responded to the last antibiotic or it's because of the prolonged duration, like 3 to 4 days of previous antibiotics. So that will comes only with the experience, and I think we need to get more experience by using antibiotics with different combinations. And before that, we need to follow these principles of antibiotic stewardship, and then only we can get this experience. And then we can propose our own individual guidelines on that, how to de-escalate, how to escalate based on that. I hope I cleared some of your points, but I think it's not enough. It is a long-lasting question for any infectious specialist. I am not an infectious specialist as well. I am just an intensivist. So I cannot conclude the answer here, but in future, maybe we can get the answers for this. Any questions, or we'll conclude the session?
Thank you, sir. That was a great session.
Thank you.